everyone. The topic of today's lecture is relining and rebasing in dentures. The learning outcomes expected of you should be able to define what relining and rebasing is, what is the purpose of relining rebasing, how to select the patient or identify the patients that are suitable for relining rebasing, and various clinical laboratory steps involved in these two procedures. Now, relining is a procedure which is used to resurface the tissue surface of a denture with a new denture-based material. So, basically, in relining, only the internal tissue surface or the intaglio surface of the denture is relined. That is, another fresh layer of the acrylic resin is applied onto the denture. Whereas in rebasing is the process of replacing all the base material of the denture. Only the teeth and the teeth arrangement remains. That is, except the teeth, the entire denture bearing area, that is the palate, the buccal flange, lingual flanges, the polished as well as the tissue surface of the denture is replaced. Except the teeth, everything is replaced. That is the difference between relining and rebasing. So, what are the general complaints of a patient that is suitable for relining and rebasing? After a period of successfully wearing complete dentures, usually at the end of 4 to 5 years of wearing complete dentures, patient may complain of looseness of the denture, soreness or inflammation of the denture bearing tissues, reduced chewing efficiency, and the aesthetic problems. That is, there is loss of facial support or the reduced vertical dimension as such, and there is less visibility of the anterior. The objective of relining and rebasing is first to establish the correct relationship of the denture to the basal tissues, that is the denture bearing tissues. And second, it is to restore the stability and retention of the denture what it was originally when the denture was made newly. And third and lastly is to restore the occlusal and the mandible, that is the vertical and the centric relationship in case of a ill-fitting. So what are the indications for relining and rebasing? First is, as mentioned, the denture becomes loose due to the resorption of the alveolar ridges. Now, as we all know, residual resorption is a continuing and ongoing process. It does not stop even after the construction of a dentures. Okay, as a result of resorption, there is decreased vertical dimension due to reduction in the height of the residual ridges. And in case patients who were given immediate dentures previously, that is immediately post extraction of the teeth, in those cases the resorption is even more faster due to the shrinkage of the tissues and the resorption of the alveolar sockets. And in some cases where the patient is unable to afford the construction of new dentures, and in those patients, relining of or rebasing would be a more economical option. Now coming to the contraindications. Contraindication 1, if patient has unresolved TMJ dysfunction, if patient has unsuccessful resolution of the inflamed and abused tissues, such as if there is flabby tissues with candida infection, generalized erythema, or such cases where there is infection, there may be denture additional hyperplasia grade 3. In such cases, we have to first resolve the tissues, and you cannot just give a relined denture to such patient. In such cases, we need to construct new dentures. Also, if there is malposition of the artificial teeth, that is initially to begin with the dentures that were made were poor in construction. Okay, if there has been fracture in the dentures or severely worn out dentition which results in excessive decrease in vertical dimension of occlusion, in such cases, or there is canting of the occlusal plane, that is the occlusal plane appears canted to either towards the mesial or the distal or towards buccal or lingually. In such cases, it is not preferable to do relining and rebasing. Also, if there is vertical dimension of occlusion is to be increased by 3 to 5 mm, that is a lot of increase in vertical dimension. In such cases, it is advisable to fabricate a new denture instead of even rebasing. So what are the general considerations prior to relining and rebasing? First is the patient should have a satisfactory vertical dimension of occlusion. Okay, so there may be some reduction in vertical dimension of occlusion due to the what you call attrition of the denture teeth, but it should not be more. Usually 1 to 2 mm of decrease in vertical dimension is acceptable, because if excessively decreased vertical dimension is there, then there will also be loss of facial support, loss of facial musculature support, there will be poor aesthetics, there will be drooping of the corners of the mouth, there can also be cheek biting and difficulty in pronouncing words and difficulty in swallowing. So all these things will compound the problem. So this is very important that there should be sufficient vertical dimension of occlusion, the centric relation and a centric occlusion should coincide with each other. That is, the patient's denture should not be so severely irritated that there is anterior rotation of the lower denture or the occlusal plane. There should be sufficient aesthetics, that is, even with the old denture, patient should be able to show his teeth, that is, there should be some amount of the tooth display, and the tissues should be in acceptable oral health. They should not be abused or traumatized tissues with candida infection. The denture base extension should also be sufficient. It should not be that the denture was to begin with had short flanges or inadequate posterior palatal seal. So, and also the patient should be satisfied with the aesthetics, that is pronunciation with the existing denture. In such cases, we can consider relining and rebasing. That is, of course, we use heat cooled polymethyl methacrylate, cold cooled polymethyl methacrylate in case of a fractured denture, or if a tooth has been lost from the denture. Usually, we'll almost always use a heat cured relining material, as it will contain less monomer, less unreacted monomer. Okay, and some other forms of methyl methacrylate, such as butyl methacrylate, and we can even use soft tissues and soft liners and tissue conditioners initially before permanent relining. That is to condition if there is any abused tissues or any inflammation or erythema, mild erythema of the tissues. In such cases, first we'll give a tissue conditioner or a soft liner, and then later we can do a definiting relining with a polymethyl methacrylate heat cure material. We also have other materials like vinyl resins and silicone materials, room temperature silicone and heat activated silicone materials, but these usually are not used in relining and rebasing. These materials are used initially when we want to make new dentures with a soft cushioning internal surface, especially in patients with sharp and with knife edge ridges, or diabetic patients who cannot bear regular polymethyl methacrylate dentures. Now coming to the pre-treatment procedures, that is preparation. First is the tissue preparation. The denture should be left out of the mouth for at least 2 to 3 days before we make the final impressions. The patient should be instructed to massage the soft tissues regularly, to use warm salt water rinses to increase the blood circulation, blood supply of the area. Then we, as I mentioned, we can use tissue conditioners initially to treat the abused tissues. This period of tissue conditioners can be used for a period of 3 to 5 weeks, which is minimum period required for conditioning any abused tissues, such as usually in the pre-maxilla or in the lower anterior mandible. In such cases, we can use a tissue conditioner, and it should be renewed every 3 to 7 days. Every 3 to 7 days, we call the patient, remove the old tissue conditioner, again put a fresh mix of tissue conditioner, again reline the denture using the tissue conditioner using a closed mouth impression technique, that is with the upper and lower denture in place in his mouth. So next is surgical management. If there is any hypertrophied tissues like Apellis fissuratum, or hypertrophic tissues in the sulcus, or there are excessively edematous tissues in the palate. In such cases, we should refer the patient to the surgery department to remove any excess flabby tissues with laser or electrocautery, and then to condition those tissues with tissue conditioners. The next step is the preparation of the denture itself. We should reduce any, because inevitably there is some loss of vertical dimension and there is slight settling of the dentures. So usually the denture flanges will appear overextended, or they will be applying pressure in the depth of the vestibule. So in such cases, we should reduce any sharp edges, relieve the frenums, the buccal and lingual frenums properly. If there is any sore spot, they should be relieved using a denture disclosing paste. Any, if there is any minor occlusal disharmony, that is, there should be equal contact of the posterior teeth on both the left and right side. If this is not there, we can do slight adjustment on the occlusal surface of the denture teeth using articulating papers. And once we are satisfied with this, then the impression surface of the denture is trimmed by 1 millimeter, that is to remove the old layer of the acrylic, and to expose the fresh layer of acrylic underneath the denture on the tissue surface side, so that it can be relined. Now, the treatment itself consists of the clinical procedures, laboratory procedures, and then there is the chairside procedures. In clinical procedures, we have the static method, that is using open mouth or closed mouth technique. We perform the relining and rebasing. A functional method is there in which the patient is asked to perform various functional movements like grinning and pouting and opening the mouth wide and doing side to side movements, swallowing movements, all these things. Then after this, there is a laboratory procedures. Once the clinical procedures are done, we take impression in the denture to be relined, and then after the words we can fabricate the or the accomplish the relining in the lab using the jig method and the flasking method. Okay, coming to the procedures, the static method that is the first the open mouth technique. So this was described by Boucher, and this can be used, and this we can do both reline both the upper and lower dentures at the same time. Basically the denture, after the trimming of the borders and after the refreshing of the denture tissue surface by 1 mm, we use the denture essentially as a special tray or a custom tray that we use for secondary impression. So we do border molding, we do take a zinc oxide phenol impression material, or we can also use monophase or regular body silicone impression material. After this, both the upper and lower open mouth impressions are taken, and then without removing the impressions, we also record the centric relation. But if we keep a softened wax bite wafer between the upper and lower denture teeth, and we gently guide the patient's teeth into the centric relationship. Okay, so we do border moldings. We freshen up the tissue surface of the denture by 1 mm. We do border molding, and we do a zinc oxide retinol or a addition silicone monophase impression. And the advantages are the selective trimming helps to make this a selective pressure impression technique. The interocclusal record that we take with the patient's upper and lower denture in the mouth is reliable. The stable bases, that is because the denture base acts as essentially as a custom tray, and we are taking open mouth impression, so it is you have more control over the impression. Disadvantages are overall relining and rebasing is a difficult clinical and laboratory procedures. So next is the closed mouth impression technique, and in this the impressions are made with the mouth closed. That is maxillomandibular dentures are relined simultaneously with the patient closing his upper and lower teeth in centric relationship. Okay, so basically centric relationship is used as a landmark for recording taking the impression. So again here we will do the record the PPS, we'll record the do the border molding, and we'll take an impression with the zinc oxide impression material. So here, since it's a closed mouth technique, we can only perform limited movements of the cheek and the lips. So patient itself is instructed to perform the various movements of to record or to trim the flanges, that is the labial and the buccal flanges. The advantages are again here the separate interocclusal allow a record will allow the operator to concentrate on recording the jaw relationship. It is possible to verify the centric relationship at the next appointment if necessary, and interocclusal records made with quick setting plaster is a reliable one. Okay, so here essentially we just take we do not guide the patient in centric. You the way patient is closing in the same way he's allowed to close, and we just inject either a impression plaster or a zinc oxide eugenol or a bite wax between the upper and lower teeth, and in that position the patient uh, does the functional movements of the denture flanges to record the borders of the denture. Okay, so next is the functional method. In the functional method, dentures are not required for the laboratory procedures. This is basically functional method we do for tissue conditioners. The step up until the preparation of the dentures are the same. We'll condition the abused tissues. These are the patient to keep the denture out of the mouth for 3 to 5 days, and then if any surgical procedure has to be done, excision of the flabby tissues and those things are carried out. And after that we'll trim the denture borders, we'll trim the internal surface of the denture by 1 mm, and then instead of doing border molding and then taking zinc oxygenol impression for relining and rebasing, we will just use a tissue conditioner plasticized resins. We will mix the catalyst and the base, and it is loaded into the denture, and then the denture is placed in the patient mouth, and the patient is done told to perform functional relining. So tissue conditions take more time to set, and they are molded by the patient's functional movements. And after this, the after maybe 15-20 minutes, the tissue conditioner is taken out of the patient's mouth, and all the excess flash, that is any tissue conditioner which has come on the buccal and labial polished surface of a denture, is then trimmed with a sharp knife or a sharp scalpel, and the junction between the tissue conditioner and the junction and the polished surface of denture is sealed with uh, a sealant material to prevent the tissue conditioner from detaching from the denture base. So essentially, functional relining is only for tissue conditioning, or for use with the soft liners, long-term soft liners or the silicone soft liners. Okay, they are excellent material. They are easy to use. They are capable of being used for many weeks, but you have to refresh them every 3 to 7 weeks. They have good diversion stability, and they bond to the denture base resins. So basically, again, the procedure for tissue conditioning is also the same. You remove any occlusal discrepancies, you create space for the tissue conditioning material. So basically, the procedure for tissue conditioning and relining rebasing is exactly the same. What the preparation. Okay. Uh, so we'll skip this thing. So tissue conditioning has to be done. Usually, you have to do tissue conditioning for 3 to 5 weeks for the tissues to return to a state of health. Along with tissue conditioners, you also need to prescribe the patient. If the patient has candidiasis or a fungal smear has been detected, then you have to give antifungal lozenges. You have to give antifungal cream and emollients, and you can also give I'm not sure what to call it here, but you can give metronidazole and chlorhexidine gels to apply for local antibiotic application onto the abused tissues. And we can also give steroid based topical gels and mouth paints for a period of up to 10 days, which have a very good result in conditioning or returning the tissue quickly to the normal state. So apart from the tissue conditioning, we also should give certain local and systemic measures to resolve the existing condition in the patient's mouth. Okay, so now coming to the laboratory procedures. In laboratory procedures, like I mentioned, we have articulator method, we have flask method. Okay, so we have made the impressions in the denture. So denture, here you can see denture is used as a special tray. We do the border molding with the green stick compound, and we reline the denture uh, with either zinc oxygenol impression material or a monophase. This is the monophase regular body impression material. Then the denture is uh, then poured. The beading and waxing is done. The denture is then poured. The stone model is retrieved from the denture. Okay, then a modeling clay is first adapted on the palatal surface of the denture, and the occlusal surface is exposed. That is, the entire polished surface of the denture is first covered with a modeling clay. Only the teeth are left exposed. Okay, then some stone is placed on the lower member and smoothened with the spatula. So this way the denture is then mounted onto the cast. Okay, so if we see here, the denture is mounted to the articulator. Okay, and on the lower surface we pour a stone, that is we can make a boxing wax frame, and we attach it to the lower member and we fill it with plaster, and then the articulator is closed, making sure that the incisal pin is touching on the incisal tip. So we get an indentation of only the occlusal surface of the denture, because we had already covered all the exposed surfaces of the denture with a modeling clay or plasticine. So now here we get only the occlusal imprint of the denture. After this, the modeling clay, everything is removed. We can even remove the boxing wax from the stone slab. So this is basically a stone index. What you see over here, this is the stone index of the occlusal surface of the denture. Okay. So after this, the impression material is removed from the denture. A thin layer of resin is removed again from the internal surface. So we remove all the impression material, zinc oxide eugenol, the border molding of the green stick compound, and if we have used a monophase impression material, it can be easily removed. Then we again freshen up the denture base from the internal surface using a large oval pear shaped burr. Okay, And once this is done, again the borders of the dentures are further reduced by 2 to 3 mm, as seen over here in the pictures. Using a Fisher burr, we'll deepen the notches for the label and the buccal frenum. And after this, the denture is ready, and then now the on the model, that is on the cast which we had poured before removing the impression material, we will create a posterior parietal seal, that is, we will scrape the posterior parietal seal area. And then after this, the separating medium is applied onto the cast, and the what do you call, we will put autopolymerizing acrylic resin onto the denture internal surface. That is, we'll put it when it is in the flowable consistency. Okay, after this, the again some resin is also applied onto the cast in the undercut areas to prevent any air entrapment, and then the articulator is closed. So because we have a stone index of the occlusal surface of the denture, so denture is stabilized vertically from using the stone index, and then the articulator, when it is closed, all the excess resin will flow out of the denture. Okay, so we have to close it tightly, make sure the incisor bit is touching the incisor table. Okay, then we can place the we allow the uh, self cure resin to reach a rubbery stage, or okay, from the fluid state it will reach the tacky stage, from tacky stage it will reach the rubbery stage. After rubbery stage, we will remove any excess that has flown onto the polished surface with the sharp scalpel, and then after that we will place it in a pressure pot in warm water at the recommended psi. That is, here you can see there is around 15 psi of air pressure, that is pound per square inch, in a warm water. We'll leave it there for 30 minutes. This is done to prevent any air voids or entrampments in the new layer of the acrylic. So after that, after 30 minutes, we'll open the pressure pot and we'll retrieve the denture, and all the flash, everything is trimmed, and this is the polished denture. Okay, so that was the articulator method. The second is the jig method. So, okay, in the jig method, this is basically a jig. A jig is similar to articulator, but it does not have any hinge. It is mainly two, like a verticulator. It has a lower base and it has upper base, and it has three pillars over it. So these pillars go into each other. So what we'll do is, again here we'll pour a stone index, and then the denture, which of course we poured after the impression. We poured the cast after doing beading boxing, and then once the cast is ready with the denture, we'll place the denture in the plaster to get an impression of the occlusal surface of the denture. So this way we get a stone index of the occlusal surface of the denture. Then we have the cast facing the upper member, and then after that the upper member of the jig is placed, and the space between the cast and the upper member is filled with the plaster. Okay, so this is basically a relining jig which is available in the labs. Okay, after this, when the plaster has set, we open the jig, and then after that, any denture teeth that need to be removed are removed from the this thing from your denture. Okay, and then we adapt a layer of base plate wax onto the cast and reassemble the jig. So here we have the stone index, the denture with the stone model, and all the borders have been filled with the base plate wax. After this, the denture and the cast is removed from the jig, and then they are placed in a your normal flask. That is, flasking is done, then dewaxing is done, and after that the denture is relined with the new layer of acrylic resin, and it is removed from the flask. So after flasking, the denture is removed from the flask, and it is replaced back onto the jig using the stone uh, uh, stone jig, or the stone index which we had made previously before the waxing of the denture borders and before flasking and acrylization. So we replace it back on the jig to verify whether the vertical dimension has increased or not, because sometimes if we add the do the relining, the denture thickness may increase. So in order to verify that the denture thickness has not increased, we replace it on the jig and re-verify it so that the jig is closing completely. Okay. So the third method is the flasking method. So basically flasking method is the same as we do in the, what you do regularly for a denture. The relining is done, the cast is poured, the denture along with the cast is then invested or flasked in the lower member of the flask, and then over this thin layer of the silicone material is applied. This is a very old picture. This usually previously they used to use a thin layer of the silicone was painted. Now we have lab putty silicones which can be applied. They are similar to your putty that you use for impressions. So it is applied onto the occlusal surface of all the teeth. Then the denture is invested, and after investing, when the plaster or stone has set, the flask is opened. Okay, and then after that the impression material is removed, the green stick, everything is removed, and then we do the separating medium is applied and new layer of acrylic is mixed and placed into the flask, into the mold, and then you do again the flasking is done, the bench curing is done. After that you do the curing cycle, and once curing is done, after that again you do bench cooling, and after that the gentle trimming and polishing is done in the normal way. So flasking method is basically what we do for normally complete dentures. We do not make any verification jig, that is before flasking the dentures. So that is the difference between this procedure and between the articulator and the jig. Okay. So heat core acrylic resin relining usually have the following deficiencies. In the articulator method, we used a self-cure relining method. Okay, whereas in the flask method, we use heat cure relining. The disadvantages of heat cure relining is the patient has to be without the dentures for a period of time, at least for 1 to 2 days. Self-cure relining can be done on the same day. Only the patient has to be without a denture for a few hours, and reheating of the original denture base during the denture dewaxing and during the denture acrylization can cause internal stresses in the old denture base material and cause warpage or cracks in the old denture base material. So we do not know this, what can happen with the old denture base material, because the relining heat cure resin material and the old denture base material may have different compositions. Okay. There will also be, there may be some processing changes in the occlusion because of the warpage of the denture. So this is a possibility, but on the whole heat core polymerizing resin is the best method for relining. Auto polymerizing material is more easier to use because it is can be finished quickly. Patient does not have to be without a dentures for a long period of time. Just using the articulator or the jig method, we can do the self cure relining, and no laboratory, no curing or the bench cooling and or bench curing. None of these procedures are required if you use a self cure acrylic resin material. Another is a chairside material method. In the chairside method, makes use of the acrylic that could be added to the denture and allowed to set in the mouth to produce instant reline. So this is only done if there is slight or minimal looseness of the denture, maybe only in the anterior portion or maybe in the posterior parietal seal area. Only we can add acrylic, trim that area, add a little bit of acrylic, self-cure acrylic in that area, and then just place in the patient's mouth and ask him to close the mouth and do the do a closed mouth impression technique, and then immediately remove it from the patient's mouth after a few minutes before any polymerization burn happen on the patient's denture bearing area, and then it is can be placed in the hot water for instant or accelerating the curing process, and after that that can be trimmed and polished and given to the patient. So chairside relining basically like using tissue conditioners. So these chairside relining resin materials set fast, so and produce less heat. So we can just use these special chairside relining resins for if we just want to reline maybe just the border is slightly short, say in the labial flange or in the buccal flange, or the postopalatal seal is there is a gap in the PBS area. In such cases, we can do chairside relining, but generally it is not recommended. Only chairside procedure we can do is the functional method utilizing the tissue conditioning material. Otherwise, all relining and rebasing should be done out of the patient's mouth, because as I mentioned, self-cure acrylic resin can cause tissue burns. Okay. So what are the disadvantages of chairside relining method? It is unpleasant to the patient. The smell is very overpowering to both the operator and the patient. Patient can have gagging, vomiting. Patient can have allergic reaction or the tissue burn because of the exothermic reaction from the polymerization. And maintaining the occlusion is difficult. When the patient bites, there may denture settling may happen, and the denture tissue surface may have porosities and roughness because the relining is being done in the mouth. It is difficult to control the saliva and all these things in the patient's mouth. Okay, the borders may become too thick, the tissue may have defect, there may be voids, there may be porosities as I mentioned, and the color of chairside relining material is not stable over time because there is a lot of free monomer in the self-cure chairside relining material. So once this monomer leaches out of the denture-based resin, there is yellowing of the uh, reline material, and because it is more porous and more rough, it will attract all the food colors that from the patient's diet and become discolored over time. And so this is the least this is a repair of the complete denture. This is not part of this lecture, so we'll just stop this lecture at this end of the relining and rebasing. So